Lots to talk about, but we're going to move on to Dr. Adam Bisaga to speak with us about naltrexone. He's a professor of psychiatry at Columbia University Medical Center and a research scientist at the New York State Psychiatric Institute.
Thank you. Thank you so much for inviting me. I'm so happy to be here and speak about naltrexone because I think this is one of those medications that is still profoundly misunderstood. And I think that's a wonderful opportunity for the Academy to clear some of this. So of the three medications that we have, two of them activate opioid receptor system. One of them not only doesn't activate, prevents opioids from activating it. So it's a very, very different mechanism. And often those two medications are kind of contrasted with naltrexone when we discuss that. There's not enough time to review evidence, but I think we can go into details, but it's very clear what is the mechanism of naltrexone effects. It does stabilize the system, and with that blocks relapse, right? Blocks development of physical dependence, relieves cravings, stabilizes affects, and allows patients to abstain from drugs and move on to learn other things that they need to learn that behavioral treatment can provide. There are some limitations like any treatment. One of the limitations that often is focused on is that it has to, in people who are actively using, we have to take care of the physical dependence first before we can initiate treatment. What I want to talk about mostly is really the concerns. There's a lot of concerns about naltrexone. Some are justified, some are not justified. Unfortunately, naltrexone is often pitted against the agonists rather than trying to figure out how they can complement each other. They are all FDA-approved medications who have proof of their effectiveness that meets the standard. And I think the idea is how to make all of them available and useful for patients. The concerns that are or misunderstandings have to do with efficacy, with dangerousness, with worsening the disorder, that the patients don't want medication, and it prevents patients from getting other treatments. Often those are the arguments, and we can certainly go through that. But what I want to address is the two real concerns we have, which is the how to initiate treatment and how to keep people on the medication. Treatment initiation is uniquely, I think, complicated for naltrexone. Retention hurdle is for all the medication because we know that patients don't really stay on medication as long as we would like them to stay. A lot of confusion about naltrexone has to do with a lot of people do not make distinction between oral and injectable naltrexone. A lot of, for example, the mortality data are on oral naltrexone, which is a very different medication. This is a study that we just published that showed that patients randomized to treatment with either oral or injectable and followed over 24 weeks are significantly more likely to remain in treatment when treated with extended-release naltrexone. So this is clearly a different kind of medication. And when we talk about really naltrexone, for most part, we are talking about extended-release naltrexone. We can certainly review the evidence, show that its effectiveness is comparable with buprenorphine, has similar effects on retention, on craving and opioid use. There may be even some advantage of having greater effect on craving or opioid use, but just for the sake, because there is few studies, as the medication was only approved in the last few years, for most part, I think that there are comparable on effectiveness on craving and opioid use. There is, of course, concern about what happens if people use on medications. People will use on all of the medications, and that's the reality that we deal with. We can certainly address what happens when people use on naltrexone versus methadone buprenorphine. The risk of overdose, which is another concern often brought up, it is very clear that while people are taking medication, the risk is comparable to buprenorphine and methadone. Again, we're talking about extended-release naltrexone, right? For all medications, for them to be effective, people have to stay on medication. So we have to really compare apples to apples and not, other scenarios, right? But it is very clear that it's easier to discontinue treatment with naltrexone. There is no withdrawal reminder, which is built into Agonist, and patients do stop medication prematurely. There are concerns about depression on naltrexone. Clearly, in most cases, depression improves once the patient stops illicit opioids. There are certainly cases of depression and suicidality. Those are rare, but they may be more frequent than with the agonists. The concern about patients don't want the medication. Most of the time, patients don't fully understand what the medication can or cannot do. Providers also don't understand when you actually do some studies, polling studies presenting for inpatient treatment, a third of them would have a preference for naltrexone, even though they didn't really know about the medication coming into the program. And then the concern is whether promoting use of naltrexone may prevent patients from getting other treatments. Clearly, all medications should be available to all the patients. Promote of one medication, I don't believe, and there is some evidence we can talk about it. It will inhibit access to other medication. If the opposite, will do the opposite. And clearly, we don't think that introduction of buprenorphine prevented methadone from having its take. I think, if anything, it destigmatized methadone. There is a lot of patients that can be treated with naltrexone, right? In many of the cases, initiation of treatment is pretty straightforward. Patients who are detoxified, as most patients who are still seeking care in this country, are patients who go into residential program or inpatient unit, are detoxified, and are discharged without treatment. Those patients can be very easily started on naltrexone. For patients who are using daily but low doses of prescription opioids, those are pretty straightforward patients to induce. Patients who use large daily amounts, injecting or using synthetic or long-acting opioids may be more difficult, but all you need is to have a protocol that can handle that. The main lesson from the study, the US study that compared buprenorphine and naltrexone, is that there was a huge difference of how many people were able to be induced, right? Of 8 sites, 4 sites did a good job, and 4 sites did a very poor job of starting naltrexone. The rates of initiation were from 60 to 95 for naltrexone, and 60 to, from I think 60 to 80 for naltrexone, and from 60 to 95 for buprenorphine. So there are programs who did better with naltrexone than buprenorphine, and we have certainly developed protocols and that show that the traditional protocol, which is based on FDA package, does have which is the graph to the left, that when you do kind of abbreviated protocol, significantly more people can initiate treatment with naltrexone. So I'll stop here. Those are some of the things that we discussed. The whole idea is really how to tell the truth to help patients and their families choose the medication that is best for them. I'll stop here. Thank you.
Well, thank you so much.